Hi. So I'm going to go over what to expect for a true pelvic floor evaluation. And this may or may not be done on your first visit, but I usually like to wait until somebody at least watches the video or has some kind of idea what I'm doing. So the pelvic floor is a group of muscles. For me, when I do a pelvic floor evaluation, I have the patient laying on my table, and I have just a flat table. I put a check sheet or something underneath them, and then I have a draw sheet over them. I step out of the room and I say, okay, I'm going to have you undress, waist down, cover up with the sheet, and then I move on from there. So I let them get dressed or undressed, and then I will proceed. So when I start the evaluation, I'm going to see what the muscles are doing. And the biggest thing with what the muscles are doing is when I say squeeze, do they squeeze? When I say bear down or relax or bulge, do those muscles move? Okay. The pelvic floor muscles, when I start, I just lift the sheet up. I say squeeze, relax, and bear down. I want to see if there's movement in those muscles. Okay. The muscles should move. If they don't, I note that in my head, sometimes they might have more movement internally than they do externally, what I can visualize or see. The biggest thing is, why are you coming in for therapy? Do you have pain? If you have pelvic pain, this is a very significant thing that I may or may not do the very first session, because any kind of increased pain or anything that I'm going to do may increase your symptoms worse. So if I'm just assessing and there's not a whole lot of trauma involved and the pain is minimal, then what I'll do is I'll actually palpate each side of the vulva. There is a muscle that goes directly underneath the fatty tissue of the vulva, and I palpate it. Do you have pain here? Yes or no? Do you have pain here? Yes or no? And then I actually go down, and it's the levator ani muscle, but from underneath. Do you have pain? Yes or no? I do the same thing on the other side. I hit 3 spots. Every pelvic floor therapist is a little bit different. I hit 3 spots on each side. Do you have pain? Yes or no? Then I'll come up to the pubic bone and I'll push the pubic bone down. Do you have pain? Yes or no? If they're not pregnant, I might go just above it and push on the bladder. Do you have pain? Yes or no? Okay? All of those things are going to give me a lot of information. Then then I bring the sheet down, I switch gloves, and then I start the actual internal component of the evaluation. So for the internal component, I will open labia minora majora, and I will place my finger at the base of the peritoneum. The peritoneum should be flexible tissue. It should move. Okay? There's a big difference if it can't move, if there's scar tissue damage, or if there's muscle tightness. And then the question is, do you have pain? Some people have a lot of pain and it's pretty flexible and it moves, but does it move? Do you have pain? Those are the big things I'm looking for. So I will push down. Do you have pain? Yes or no? I'll go to one side. Do you have pain? Yes or no? I go to the other side. Do you have pain? Yes or no? From there, for my experience and what I've been doing in the past, I then warn you ahead of time, but I'm going to go all the way to knuckle 3. At knuckle 3, I can reach all the pelvic floor muscles from internal, which is great for me. Then I have you squeeze, relax, and bear down. That is going to give me, is there something happening or not happening that's different than what I saw from the outside? Okay. Then from there, everything from my patients, is based on a clock. And that is because I have a lot of patients that have a lot of pelvic trauma, and I want to give them a warning of where I'm going, when I'm going, before I'm going there, so they can anticipate it, and so that there's a good communication between the both of us. Okay. Once I'm at knuckle 3, I stay at knuckle 3 until you say stop. You have complete control of this entire situation. We do not have to continue. Or until I'm done. Okay? I don't go in and out. I don't figure out what muscles are happening. If I can't reach them, I will let you know. And so from there, everything's based on a clock, as if you're looking at the pelvic floor. Okay? So 12 o'clock is towards the top, 6 o'clock is towards the bottom, and then we have 3 o'clock and 9 o'clock. So what I'll do is I don't push down at 6 because that's your colon and it does not feel good for me to push on it. And I will turn towards 7 or 5, depending on which side of your body I'm on, turn towards, let's do this side. I will turn and I'll push down. Do you have pain, yes or no? No? Okay. I'm going to move to 4 o'clock. I'm going to push down. Yeah, I don't like that. That doesn't feel good for me. Okay, well, I'm going to hold that position until the pain goes away. There's several techniques that I can do to release the tissue from inside. But the biggest thing is, do I feel flexible muscle? Is there pain? And is there any sort of other dysfunction or another symptom that you feel? So there's some important muscles to take into consideration in the pelvic floor. But 4, 5, 7, and 8 are going to be your levator ani, or they elevate the anus. At 3 o'clock and 9 o'clock, our pudendal nerve pops out. The artery, vein, and nerve pop out. That is a huge source of pudendal neuralgia or pelvic pain that may be associated with the nerve. At 10 o'clock and 2 o'clock is our obturator internus. That is a very important muscle to learn. That is not a pelvic floor muscle. You can reach it externally, but it's really difficult. So I actually love treating it internally. I feel like I can get a really good release and I can resolve a lot of hip pain that may be associated with the obturator. Okay. At 1 o'clock and 11 o'clock is another muscle more related to the bladder. At 12 o'clock, the bladder is right there if I come out just a little bit. So if you're coming to see me for interstitial cystitis, urgency and frequency, and we're doing all the other things and we're still not getting resolved, or you want to know from the beginning, like I want to know all my issues from the beginning, then I'll do the internal component and see if there's other things that may be associated with your issue that you may not actually know are related. And so then for the pelvic floor evaluation, I will, once I'm done assessing the muscles, I've already assessed the muscle strength. Is it contracting? Is it relaxing? Is it coordinated? I'm checking the muscles and to see if you have any trigger points. I'll release them while we're there. If we have time or if you are a candidate, I will then check for a prolapse. Prolapse is a whole nother issue and a whole nother conglomerate of symptoms. But when I do the checking for prolapse the first time, I do it lying down on the table, and I'll do it at the very end. So I'm going to do a quick version of that, and then later on we'll talk about different ways that you can assess for prolapse yourself and assess for how a practitioner can do a prolapse testing in a standing or squatted position. Okay, so if I'm just doing it at the end just to see what's going on, I will back my finger all the way out to about knuckle 1. This is the only other time I'm actually looking. Otherwise, I'm sitting next to you trying to figure out if you have pain, and I'm actually trying to distract you with normal conversation. So what I'll do is I'll back out, I'll open labia minora majora again, I'll insert my second finger, and I'll push down. And then I'm going to have you bear down or bulge for about 6 seconds. The purpose of that is to see if the tissue moves. Does it stay? Does whatever organ is drooping, does it stay? Or does it bulge and move outwards? So by pushing my fingers down, I'm blocking the back side or the rectum, and I'm specifically looking for the top, okay, the bladder. Then I'll push up and I will block the bladder, and I'm going to see if you have a rectocele or the rectum is kind of bulging into the vaginal canal. I've already checked for the top or the uterine or an apical vaginal vault prolapse. I happened to do that at the very beginning. I just didn't tell you. When I have you squeeze, relax, and bear down, my fingers at knuckle 3, you squeeze, relax, and bear down, and I'm feeling for something at the tip of my finger. If you haven't had a hysterectomy where your cervix is removed, I can actually feel the cervix drop into my finger. It feels like the tip of the nose. And so it's really, really easy to palpate whenever you bear down. So that's a very quick, very general version of what a pelvic floor evaluation entails. It can be very complicated, it can be very painful, so sometimes we don't get to all the things. But it's really important to understand that the provider is trying to figure out if the muscles are involved, if the nerves are involved, especially if you're coming in with symptoms of leaking. Sometimes it's actually tight muscles and not weak muscles. So trying to figure out what the true source of your issue is going to be a huge help in your progress and prognosis for physical therapy. So I hope you enjoyed and look forward to more videos about pelvic health. Subscribe, please.